Linking on my brain. Okay. Linking on my brain. I got linking on my brain. Whoa.
Diaphragm Introduction. The diaphragm is the chief muscle of quiet respiration. Though it separates the thoracic and abdominal cavities, it gives passage to a number of structures passing in both the directions. Since it develops in the region of the neck, it continues to be innervated by the same loyal nerve despite its descent to a much lower level. During inspiration, the central tendon is pulled by the contracting muscle fibers, so that inferior vena caval opening is enlarged, helping in venous return to the heart. This venous blood is pumped to the lungs. The air also gets into the lungs during inspiration. So both the venous blood in the capillaries and air in the alveoli come close high in the lung tissue, separated by the lining of the alveoli. The exchange of gases takes place, carbon dioxide is expelled in expiration and purified blood is returned to the left atrium. Dissection. Strip the peritoneum from the under aspect of the diaphragm and expose its crura on the anterior surfaces of the upper 2 or 3 lumbar vertebrae. Find the arcuate ligaments. Expose the slips of diaphragm arising from the internal surfaces of the remaining costal cartilages and identify the intercostal vessels and nerves entering the abdominal wall between them. Locate the main openings in the diaphragm and identify the structures passing through each one of them. Explore the other minor openings and the structures traversing these. Definition. The diaphragm is a dome-shaped muscle forming the partition between the thoracic and abdominal cavities. It is the chief muscle of respiration. Muscle fibers form the periphery of the partition. They arise from circumference of the thoracic outlet and are inserted into a central tendon. Origin. The muscle fibers may be grouped into 3 parts: sternal, costal and lumbar. The eternal part arises by 2 fleshy slips from the back of the xiphoid process. The costal part arises from the inner surfaces of the cartilages and the adjacent parts of the lower 6 ribs on each side, interdigitating with the transversus abdominis. The lumbar part arises from the medial and lateral lumbocostal arches and from the lumbar vertebrae by right and left crura. The medial lumbocostal arch or medial arcuate ligament is a tendinous arch in the fascia covering the upper part of the psoas major. B. Medially, it is attached to the side of the body of vertebra L1 and is continuous with the lateral margin of the corresponding crus. Laterally, it is attached to the front of the transverse process of vertebra L1. C. The lateral lumbocostal arch or lateral arcuate ligament is a tendinous arch in the fascia covering the upper part of the quadratus lumborum. It is attached medially to the front of the transverse process of vertebra L1, and laterally to the lower border of the 12th rib. The right crus is larger and stronger than the left crus, because it has to pull down the liver during each inspiration. It arises from the anterolateral surfaces of the bodies of the upper 3 lumbar vertebrae and the intervening intervertebral discs. D. The few crus arises from the corresponding parts of the upper 2 lumbar vertebrae. The medial margins of the 2 crura form a tendinous arc across the front of the aorta, called the median arcuate ligament. Muscle fibers. 1. From the circumferential origin described above, the fibers arch upwards and inwards to form the right and left domes. The right dome is higher than the left dome. In full expiration, it reaches the level of the 4th intercostal space. The left dome reaches the 5th rib. The central tendon lies at the level of the lower end of the sternum at 6th costal cartilage. The downward concavity of the dome is occupied by the liver on the right side and by the fundus of the stomach on the left side. 2. The medial fibers of the right crus run upwards and to the left, and encircle the esophagus. 3. In general, all fibers converge towards the central tendon for their insertion. Insertion. The central tendon of the diaphragm lies below the pericardium and is fused to the latter. The tendon is trilobar in shape, made up of 3 leaflets. The middle leaflet is triangular in shape with its apex directed towards the xiphoid process. The right and left leaflets are tongue-shaped and curve laterally and backwards, the left being a little narrower than the right. The central area consists of 4 well-marked diagonal bands which fan out from a central point of decussation located in front of the opening for the esophagus. Openings in the diaphragm. Large or main openings in the diaphragm. The aortic opening is osseo-aponeurotic. It lies at lower border of the 12th thoracic vertebra. It transmits a aortothoracic duct and azygous vein. The esophageal opening lies in the muscular part of the diaphragm, at the level of the 10th thoracic vertebra. It transmits esophagus, gastric or vagus nerve and esophageal branches of the left gastric artery, with some esophageal veins that accompany the arteries. The vena caval opening lies in the central tendon of the diaphragm at the level of the 8th thoracic vertebra. It transmits inferior vena cava branches of the right phrenic nerve and lymphatic of liver. Small openings in the diaphragm. One each cruce of the diaphragm is pierced by the greater and lesser splanchnic nerves. The left cruce is pierced in addition by the hemiazygos vein. 2. The sympathetic chain passes from the thorax to the abdomen behind the medial arcuate ligament or medial lumbocostal arch. 3. The subcostal nerve and vessels pass behind the lateral arcuate ligament or lateral lumbocostal arch. 4. The superior epigastric vessels and some lymphatics pass between the origins of the diaphragm from the xiphoid process and the 7th costal cartilage. This gap is known as Larry's space or foramen of Morgagni. 5. The musculophrenic vessels pierce the diaphragm at the level of 9th costal cartilage. Relation superiorly pleura and pericardium. Inferiorly, 1 peritoneum liver fundus of stomach spleen kidney and suprarenals nerve supply, motor. The phrenic nerves are the sole motor nerves to the diaphragm, ventral rami C3, C4, C5. Sensory. The phrenic nerves are sensory to the central part, and the lower 6 thoracic nerves are sensory to the peripheral part of the diaphragm. In addition to the diaphragm, the phrenic nerves also supply sensory fibers to the mediastinal and diaphragmatic pleurae, the fibrous pericardium, the parietal layer of serous pericardium, and the part of the parietal peritoneum lying below the central part of the diaphragm. Through its communications with the phrenic branches of the coeliac plexus, the phrenic nerve is also distributed to the falciform and coronary ligaments of the liver, the inferior vena cava, the suprarenal glands, and the gallbladder. Functions. 1. The diaphragm is the principal muscle of inspiration. On contraction, the diaphragm descends, increasing the vertical diameter of the thorax. The excursion of the diaphragm is about 1.5 centimeters during quiet breathing. In deep inspiration, it may be from 6 to 10 centimeters. 2. The diaphragm acts in all expulsive acts to give additional power to each effort. Thus before sneezing, coughing, laughing, crying, vomiting, micturition, defecation, or parturition, a deep inspiration takes place. This is followed by closure of the glottis and powerful contraction of the trunk muscles. 3. The sphincteric action in lower end of esophagus is due to the contraction of the intrinsic muscle in the lower 2 centimeters of the esophagus. The position of the diaphragm in the thorax depends upon 3 main factors. These are as follows. A. The elastic recoil of lung tissue tends to pull the diaphragm upwards. B. On lying down, the pressure exerted by the abdominal viscera pushes the diaphragm upwards. On standing or sitting, the viscera tend to pull the diaphragm downwards. C. While standing, the muscles in the abdominal wall contract, increasing the intra-abdominal pressure. This pressure tends to push the diaphragm upwards. In sitting or lying down, the muscles are relaxed. Because of these factors, the level of the diaphragm is highest in the supine position, lowest while sitting, and intermediate while standing. The higher is the position of the diaphragm, the greater respiratory excursion. Development. Diaphragm develops from the following sources. 1. Septum transversum forms the central tendon. 1. Pleuroperitoneal membranes form the dorsal paired portion. 2. Lateral thoracic wall contributes to the circumferential portion of the diaphragm. 3. Dorsal mesentery of esophagus forms the dorsal unpaired portion. Hiccup or hiccup is the result of spasmodic contraction of the diaphragm. It may be, A. Peripheral, due to local irritation of the diaphragm or its nerve. B. Central, due to irritation of the hiccup center in the medulla. Uremia is an important cause of hiccup. Shoulder rib pain, irritation of the diaphragm may cause referred pain in the shoulder because the phrenic and supraclavicular nerves have the same root values, C3, C4, C5. Unilateral paralysis of the diaphragm, due to a lesion of the phrenic nerve anywhere in its long course, is a common occurrence. The paralyzed side moves opposite to the normal side, i.e. paradoxical movements. This can be seen both clinically and fluoroscopically. Eventration is a condition in which diaphragm is pushed upwards due to a congenital defect in the musculature of its left hull, which is represented only by a fibrous membrane containing a few scattered muscle fibers. Diaphragmatic hernia may be congenital or acquired. Congenital hernia, retrosternal hernia, it occurs through the space between the xiphoid and costal origins of the diaphragm, or foraminoamorgagni, or space of Larry. It is more common on the right side and lies between the pericardium and the right pleura. Usually it causes no symptoms, Fig 26.4. B. Posterolateral hernia, this is by far the commonest type of congenital diaphragmatic hernia. It occurs through the pleuroperitoneal hiatus or foramen of Bokdalik situated at the periphery of the diaphragm in the region of attachments to the 10th and 11th ribs. It is more common on the left side. There is a free communication between the pleural and peritoneal cavities. Such a hernia may cause death of the infant within a few hours of birth due to acute respiratory distress caused by abdominal viscera filling the left chest. This hernia requires operation in the first few hours of life. C. Posterior hernia, this is due to failure of development of the posterior part of the diaphragm. One or both cruces may be absent. The aorta and esophagus lie in the gap, but there is no hernial sac. D. Central hernia, it is rare, left-sided, and is supposed to be the result of rupture of the fetal membranous diaphragm in the region of the left dun. Acquired hernia, traumatic hernia, it is due to bullet injuries of the diaphragm. A. Hiatal hernia, it may be congenital or acquired. A congenital hiatal hernia is due to persistence of an embryonic peritoneal process in the posterior mediastinum in front of the cardiac end of the stomach. The stomach can roll upwards until it lies upside down in the posterior mediastinum. It is, therefore, called a rolling type of hernia. It is a rare type of hernia where the normal relationship of the cardio-esophageal junction to the diaphragm is undisturbed, and, therefore, the mechanics of the cardio-esophageal junction usually remains unaltered. Accu-Ironed hiatal hernia or sliding type is the commonest of all internal hernia. It is due to weakness of the phrenico-esophageal membrane, which is formed by the reflection of diaphragmatic fascia to the lower end of the esophagus. It is often caused by obesity, or by operation in this area. The cardiac end can slide up through the hiatus. In this way the valvular mechanism at the cardio-esophageal junction is disturbed, causing reflux of gastric contents into the esophagus. Summary of diaphragmatic hernia: A. Congenital, I. Retrosternal. 2. Posterolateral. 3. Posterior. 4. Central. V. Acquired, I. Traumatic. 2. Hiatal. Congenital hiatal hernia, acquired hiatal sliding hernia. Mnemonics: diaphragm apertures, spinal levels T8 and T10. Inferior vena cava, 8. Esophagus, 10. Aorta, 12. The sole motor nerve supply of the diaphragm is phrenic nerve, C4. It develops in the neck, but is carried downwards due to developmental factors. Inferior vena caval opening is in the central tendon. During inspiration the opening gets dilated, allowing increased venous return. Right cruce of diaphragm acts as a sphincter at the gastroesophageal junction. Hiatal hernia may be of rolling or sliding type. The rolling type is usually congenital while the sliding type is usually acquired.